So hi, everybody, and thank you for joining us tonight with Dr. Bess Pierce and the Piezo-Wave Users Forum. Dr. Pierce is a diplomat of both veterinary sports medicine and rehab and veterinary internal medicine, and is running a program out of the University of Missouri. She has done amazing things with the Piezo-Wave and a great source of knowledge. If you will all keep your microphones muted unless you have a question. Of course, we always encourage questions and interactions. We're just doing our best to keep the background noise down for our recording, because the recording will be on our website in a week or two. Takes time, but it will be there if you have friends that have missed. So turn it over to Dr. Bess Pierce.
All right. Thank you, Cindy. I appreciate it. It's always fun to get together for these things because I always learn as much from the group and what you all are doing out there for shockwave therapy. I tend to focus a little bit more general, but we will, since we are in a piezo forum, we will talk specifically about the application of this, of this wave form. So I always think it's worth looking again at kind of the, what's the basic science of it, because that will help you when we have so many gaps in our clinical application and our how do we apply this, then the basic, always returning back to the basic science can help you. So if you feel really strong in this area, go step away, have a cup of coffee, and we'll be back with the case stuff. But please, Dr. Cindy, I will leave it to you to watch the chat. Is that good?
Yep.
Okay. You just let me know if you, and so throw things in the chat, raise your hand, whatever you'd like to do. Happy to answer questions as we go along. So let's get started here. If I can, there we go. Of course, shockwave is a mechanical stimulus in the form of a radial or focused shockwave. And we'll talk about the difference between those two, just to remind everybody, kind of how those apply clinically, but we're really going to be, no pun intended, focusing on focused shockwave. And so because radial shockwave is actually a form of pressure wave and might have more applications for maybe some myofascial work, but not so much for that focused extracorporeal shockwave that we are trying to apply to damaged tissue. Like most of our modalities have some form of energy that is then has this transduction or change into a chemical, cellular level, has a chemical change that is then going to induce changes within the cellular structure, within metabolic outputs and genetic expression. And so with shockwave, it is literally this mechano transduction from this physical focused wave of energy that is going to, again, it's that mechanism by which the cells convert their mechanical stimulus into chemical activity. And that chemical activity then causes these biochemical alterations in signaling outcomes at the cellular level. And that's where we get these specific areas that are going to then promote healing. And we're going to, we'll see, kind of follow some of those pathways here in just a second to, again, give you an idea or to remind us all of what kind of biochemical outcomes we're looking at with shockwave largely. This, if anybody knows of someone, or if you've had it yourself, lithotripsy, this is the origins of the extracorporeal shockwave that we use at the tissue level. It is much milder, with lithotripsy. And it used to be that they would float you in a bath in like a sling, and then use the much higher powered lithotripsy to actually break up your kidney stones. And so now they have these really amazing, super fancy machines that you no longer have to do that, because they can focus it and actually direct that to the to the kidney stone itself. So anyway, but this is the origin. This is where, this technology comes from. So we have that focused shockwave that is going to start with this broader base coming from the shockwave source. And so that will be created, and we'll look at that in the next slide, is kind of how do different machines create the shockwaves, and is going to focus either by depending on, and of course in piezo wave, we have all these standoff pads that we can use. And so it's going to focus it at different depths within the tissue. And this is where you're going to get basically your maximum flux density of energy that's delivered at that focused target tissue, at that focused point. Your, excuse me, your radial shockwaves are going to be, and shockwaves are again a bit of a misnomer here, and so really it should be more accurately termed pressure waves. Is going to start with your point of maximum density is at the source itself, and then those waves spread out. So you're not going to, you can see that penetration is definitely affected. And so it's a different way of delivering again, delivering that mechanical energy to the tissue. Most of the work that has been done as far as ligaments, tendons, connective tissue, well, I shouldn't say connective tissue, but ligaments and tendons, and bone healing is in the focused shockwave group. Your radial shockwave, we see some evidence for maybe some myofascial response to therapy, but really your skin, it's going to be, there's not as good a evidence for support, certainly for tendinopathies. And that's what we're kind of focusing on a bit today, are tendinopathies. So again, just two different, they are two different trodes, or two different attachments that you use on most machines. Now, I don't want to say to confuse the issue, but one of the things that the piezo machine has is a focused, what we call a linear probe. While you might think that that might be a radial, that is actually a focused shockwave probe. It has it focuses along a line. So instead of having that point of maximum, your EFD, your target, is going to be focused along a line. So I find that one very useful for kind of a broader application across a linear. So maybe say if you are treating a tendon, if you are, we use it a lot for when we treat lumbosacral issues, because we can cover, a little bit wider path, but it's still a focused shockwave. So it is still bringing it to, and you have different standoff pads that allow you to focus that shockwave below the skin at different levels, depending on the depth that you need to penetrate. So you have kind of two different options, are these, the round trode with the standoff pads that bring it down to literally a point, and then the linear probe that's going to focus the shockwave along a line. So I don't know, Cindy, if you want to put adding details on that part, just from the equipment standpoint.
Just that they both work great. And
They
they're
do.
fun. The straight line of our linear probe is very unique.
It is, yes.
And I think it's definitely something that we tend to use when working around the back and the LS. So super fun. If people don't have it, we let you try it. So there you go.
Yep, there we go. There we go. So different ways that the shockwaves can be created, and these are just kind of across different machines. We'll focus, of course, again on our piezo, our array of crystals that are activated and then are focused to then leave the probe, and then this focal point is adjusted with the standoff pad. So whether you want it, kind of at the surface versus all the way up to the particular trade that we have, the kind of the catch-all one, I guess, for small animal, is a 30 standoff pad. So 3 centimeters of focus depth is going to be your depth on that. Now, equine, I don't know if we got any equine folks on tonight, but equine has, gosh, it's 180. It's
we have a 60 and 100 depending on.
Okay.
Yeah.
A 60 and
one
100.
you choose.
Yep. Yep. And so clearly we are not going to pull that out for the Chihuahua, or the, you're not going for that probe, but just know that there are probes that offer you greater penetration and, depth, that you can work with, but those get into the equine type probes. But, you have some that, so some sparks are created across, liquid medium and creates the pulse wave. Some of them are, almost like a speaker type thing where that vibrates. You have flat coil, cylindrical coil. So there are just different ways, to create that shock wave, and we'll leave it at the simplest simpler. If for some reason you're looking across machines, then, knowing that though is important. The different machines create their waves differently, and that has absolute implications for how the energy is delivered to the tissue. All right, but again, we're going to focus on our piezo. But one of the things that has been noted for the piezo is that it's too fine of a, it's too weak or too fine of a point of focus. And quite frankly, that is the entire point of Shockwave. Again, no pun intended, is that we are able to put that focal point on the lesion. And so that just speaks to across many, many things. And we'll talk about this as kind of developing how do we optimize our use of Shockwave. And one of it is to know what your lesion is and know where you're treating and be able to put that. And that's one of the greatest advantages to me of this particular system, is that we can literally pinpoint that we can focus that energy density down to that, that focal point in the tissue. Now, not to say that we don't get penetration beyond that. Clearly you can see where we've got, but it's this concentrated focal point here. And we see here the ones and twos match over here, our wave here, where we have the positive energy wave. So that's the peak pressure, that very high, energy wave. And again, when you have lithotripsy, it's like way up here. I mean, it's this huge, very powerful wave. But for our Shockwave, we're gonna have that peak pressure, but then this negative energy density creates this like vacuum within the tissue that we think we get as much, if not more, biological activity from this negative energy density and this vacuum that's created at the cellular level. And so you do have, but it's this biphasic wave here that you have peak pressure, and then you have a negative pressure, and then comes back up, and that's repeated over and over. And of course, this is nanoseconds wide here, this actual pulse. Okay. All right, so between those two, you get your total energy density, which is essentially your dose, so to speak. And I think I put this also at the end. I'll apologize for that, but things that we can do to make sure that we optimize our delivery of energy to the tissue. You make sure when you're using your piezo that you've got an appropriately sized standoff pad. And I will absolutely say that the best way to determine that is through ideally musculoskeletal ultrasound imaging. We actually measure the depth of the lesion that we are treating, and applying, and then picking our standoff pad in accordance with that, where we want to deliver that, again, that peak energy at the focal point. Now, but I also get it that, in practice that's not always something that is available. And so if you are doing something like an Achilles, that's pretty straightforward. Just whip out your little, millimeter ruler and measure, to where you're, on that particular dog, say, where is the mid body of your tendon, for depth. And then that can help you kind of pick your best standoff pad. So I would definitely encourage you to do that. The other big thing is that air, just like in any ultrasound created wave, is the enemy of good delivery of energy, or in the case of diagnostic ultrasound, is the enemy of getting a good image back, right? Because it scatters the beam, and so you have that interference with air in the hair. So two things that make that is you need to shave. Yes. And so, and this is another thing that Darshini and I kind of go back and forth, because I realize that not every situation, is going to be where the owners are going to let you shave. But if we're talking kind of, the ideal way to ensure that we have as little interference with the air pockets that are trapped within the hair, we should shave, to the skin level. That's the first thing. The other then, of course, is the coupling agent, the gel agent, that we want to make sure that we have no bubbles. And part of that is starting with the trode and the standoff pad, is be sure that you have that good, where you push down, make sure, physically look at while you do that, make sure all your little air bubbles have gone off to the edges. And that, because it's amazing that even if you, and I don't have my notes up there, they're at the bottom of my slides, but I think it's if you disrupt, or if you if you have a bubble that is only 4%, blocks 4% of your field, that decreases your delivery of energy by like 20%. So it's a significant thing. Hang on, let me get rid of that. So air bubbles can be, especially when you're talking about treating a small target area within the tissue, making sure those air bubbles, those can have a significant influence on delivering energy to that tissue. And then once you get that standoff pad, of course, your ring's in place, that all should be good. And then you want to, the recommendation, and I actually didn't know a lot of this until I started looking at lithotripsy, from the human, there are like human standards for treatment. And I was like, is to put your coupling gel directly to the pad. Don't also add it to the patient, because when you put those two things together, you can create an air interface between those. So that was the thing I was like, because we did that all the time. You slather your patient with gel and you put some gel on the trode, but when you put those two together, you actually can get air bubbles. So we have just started putting it on the trode head, as recommended on the human side. So again, no direct studies. They've looked at it on the human side. So I thought that was very interesting. And so things that can disrupt, like, the other thing I do is I shake my bottles a lot, because I think it's just like a clinical habit for me. I shake everything. And so I shake my bottles, you're creating air in there. So just stop, give it a good whack to get it all down there. And then same thing, gloved hands, all of that. So just think about how you're applying your gel. I never knew that there was so much about gel. We always just slap it on there and go for it. But when I did read about how small of a bubble can disrupt a major part of your energy delivery, it's worth looking at. So who knew, right? I didn't know until I started looking at it. So FYI. Okay, there's been some great basic science that has been done. We kind of talk about these. We know, that we have these main biochemical cellular effects, and that we can affect the inflammatory response. We can, and it used to be that we thought we had to have really high doses on our EFD, our millimeters per millijoule delivery, to incite an inflammatory response. And that is just, we know this, we know the basic science much more so, and that is not the case. We don't need to have those very high levels. And I'm still amazed. I mean, part of it for the horse side is to get it to the tissue itself, because those are so much larger patients, and we got to have that penetration. But we just don't, we don't use those, equine is up into that 0.3, 0.4, sometimes 0.5 millimeters per millijoule, or millijoules per millimeter squared. And those are really high levels. And so I've gotten away from, and I think, Dr. Cindy, we've talked about, I think you same thing, you've just gotten away from using that sort of level.
Yeah, I will say it's kind of been a discussion that I've had with a few people, is why does equine require so much energy, or are we overdosing? One comment that Dr. Adair had, which always learning, that uh, dogs have much more connective tissue in their muscles, and so I'm thinking like more fascia and stuff, to absorb, to that the shockwave will move, and horses don't have that and tend to be very dense.
Okay,
I don't
yeah,
know.
which I could see that. Yep.
Um,
So yeah, so just keeping in mind that we certainly don't need to incite that strong inflammatory response. We see all of this happen in the face of using those a little bit lower doses that we've seen on the and I'm sticking with small animal side, guys. I am not equine at all. I am small animal. I am canine on the sports medicine side, and small animal and for internal medicine. So and canine feline for ABVP. So I do not speak for the equine side. So if we got any equine folks on, please step up. Happy to hear. We do get angiogenesis, partly as a result from influencing nitric oxide. Okay, is one of the major pathways for that. We get cell proliferation in influencing upregulating some of the cell growth factors, and also inducing or kind of kickstarting ATP. And then collagen synthesis, the upregulation of normal collagen is one of the biggest things that we are using when we're treating our tendinopathies, or one of the biochemical outcomes that we are capturing when reaching for Shockwave. And we see it with therapeutic ultrasound, and that was kind of what I consider our precursor, so to speak, for Shockwave. We see a lot of the same things, but it takes longer, takes more treatments. We don't get quite the same effect at as quickly. So, okay. And just another different way of looking at it here at the actual tendon level itself. And again, this is a great article to read that's just come out not too long ago, but looking at the biological response of shockwave therapy to tendinopathy in vivo, which is really nice because, looking at it in the actual patient. But again, we get upregulation of ATP and some of those growth factors, nitric oxide. We get upregulating MMP. Again, more growth factors, collagen synthesis, and then stimulating our angiogenesis are kind of our biggest effects that we see, because tendons are notoriously avascular, right? And that's especially as they scar. There's just not a vascular response that is going to happen normally, and the whole idea is that we need to kickstart that and upregulate some of these mediators to get that tendon, what I consider, sort of kickstarted, and try and get that healing cycle to continue, because it shuts down really rapidly in damaged tendons and ligaments. All right. And then from kind of the muscle standpoint, again, just a different way of looking at it. And mainly over here, we see our macrophage. We can have those anti-inflammatory effects, again, because we're not using levels that are going to really highly stimulate or to actually cause damage, so that we have an inflammatory response, which was our first go-to, probably built kind of off of lithotripsy, in its early days. But we just don't need that. So I'll pause here. Any questions or thoughts out there? And I know it seems that, the theory part is like, oh, do we really need this? But it's so important because we lack very specific studies for most of the stuff that we treat. And so knowing what knowing what the basic science of it is, and then knowing the target tissue that you want, you can put those two together to come up with a reasonable treatment approach that can help guide you through, and calling Dr. Cindy. That's what we all do. So I have this, the last time I did that was with a raptor. So yeah, I have this bird. Can I treat this?
Oh, Lord.
Clinical outcomes, of course, that tissue repair effect, in which we're looking at mainly, tendons, ligaments, bone healing. Of course, that's another where, again, we're focusing on tendinopathies today, but bone healing is a big area where we use this here at the university, is if we have delayed unions, not so much non-unions, they're usually but in conjunction with surgery, we will use Shockwave to treat for that particular part of upregulating our osteoblasts and promote our bone healing, for much of the same reasons that we see tendon healing. Those same types of downregulating inflammation, upregulating growth factors, is that we'll see that bone healing effect. So the other thing that we use it for is a lot for the analgesic effect. This is my number one go-to that I use for lumbosacral pain or discomfort for the initial treatment. This is what we used on our military. I spent 30 years in the Army Veterinary Corps, and so I have a long career treating crazy military working dogs, and a lot of them get lumbosacral disease and are very uncomfortable. And I found this to be one of the best tools that it could pull out. Of course, you always have, injections available. You have those joint injections where you can get into the LS space. But I love Shockwave and so if we have our working dogs that have chronic lumbosacral disease that is, manageable. It's in its early stages, so they can still work, but we're needing to keep them comfortable we'll use this, for a series when they flare up, and then kind of for tune-ups is what we call them. But a lot of that analgesic effect is decreasing the substance P in the area of application, and actually affecting the nerve fibers. We do get and then this changing the permeability of the cell membrane and the influx of calcium within the cell level, similar to what we see with pulsed electromagnetic field. We see some of that same action with Shockwave. And then just the serotonergic system, again, just bringing those natural analgesic compounds helps to upregulate the production of those. So we get a good analgesic effect from it. Which is why you have to be a little bit careful, post they may be, and again, we saw this when we were using higher doses, is that we still do, but we would warn the owners that we could see, the next day or so that they might be more painful or more tender. And again, using those lower doses, we don't see that so much anymore. But, we again, still warn them, but often after 24 hours, they feel a lot better, and then they get active. And so it does not instantly fix the underlying disease. And so you have to warn owners that, then they might be sore at the end of day 3 or 4 because they have had this analgesic effect. And we see that much more so than we see the opposite of where they are, uncomfortable following treatment. So just again, warn owners of that. But again, our just another way to look at our tissue repair effect, our neovascularization is a big thing, enhanced collagen synthesis and maturation, and then scar, it's anti-fibrosis, and that's why we can actually treat scar lines with it, and help to reorganize that collagen and increase the health of the myofascial tissue, period. Our osteogenesis effect, again, I have this in there just as a FYI for, that this is another very good application for Shockwave, is to promote bone healing. If you have a patient that you may need to, need this, for application. Excellent for stress fractures. We see what in a lot of we've had a recent kind of run, no pun intended, on agility dogs that have had metacarpal or metatarsal stress fractures, and is very successful for treating those. And they've done very, very well. And there's some very good studies on the human side for, soccer players are a big one. They often stress fracture their metatarsals, and Shockwave is an excellent treatment for that. And then also military recruits, because they end up, pounding on their feet and just causing stress fractures, and they're treated with Shockwave and do very well. All right. So probably just like all of you all, managing musculoskeletal soft tissue pain is a big application that we use clinically. We have also been, and because of this, we also, another application that we use it for, and I think I have the list here in a minute, but we are using it more for osteoarthritis and osteoarthritic joints, to where we can, again, manage that. Because I think we certainly, there's no thinking to it, that we certainly get better penetration with our Shockwave than we do with our laser. And that's where we'll reach, especially if we have these bigger dogs that I'm like, pretty sure we're not getting down there with laser, that will pull out Shockwave for their joints and to treat their joint capsules. So But it doesn't have to necessarily be a deeper lesion. You can treat superficial and soft tissue injuries with Shockwave, and then relief of acute and chronic pain, and to just help restore mobility and help be part of that multimodal approach to help get that animal on its feet, kind of back to a more comfortable mobility stage, and then stimulating bone growth and tissue regeneration, of course. Excuse me. So like many things where, I'm in the university, my first question is always going to be show me the money, is show us the studies. And so I don't, here's the one of the bigger reviews here, which is relatively small because there are not that many studies on the veterinary side, but looking at scientific evidence for clinical effects of shockwave in horses, dogs, and cats. The truth of the matter is there's limited evidence, mainly because we don't have big studies. We just don't have the studies for it. So so some had good evidence for, or reasonable evidence for, short-term pain relief, ligaments, osteoarthritis, ligaments, tendons, and their conclusion was it warrants, they seem promising and warrant further exploration with high quality studies. So just like most of veterinary medicine, we base our entire veterinary medicine treatment on N of 8, and it just, we have small numbers. We just we don't have those huge studies like they do on the human side. So there is a fairly recent systematic review that looked at, kind of what's out there for studies. Now, having said that, there are some specific things that they looked at the same on the human side, and of course, a lot more studies, a lot higher numbers, and they're based on that, we're seeing more solid evidence for use for pain management, which not surprising, but tendinopathies, things like plantar fasciitis, axial pain, myofascial, same lumbosacral, osteoarthritis, bone lesions. So they're seeing better once you get those better numbers, or seeing more solid evidence for that. So I fully expect that we are going to fall, because my clinical and everybody's clinical impression is yes, that we do see this. However, we do need, we need those studies to back that up completely. So this is what our major applications for it here, and I think probably most everybody else, this is what we're looking at, is our osteoarthritic joints, our tendon injuries, our ligament injuries, non-unions, delayed unions, and then just more, more stuff that's a little bit more esoteric here over on the right. And some of these things like is still scar tissue and muscle. I tend to still go towards therapeutic ultrasound just for tissue extensibility. But that's just my own, then trigger points and all that. I do that with dry needling. So, I don't always, but I know we've, Dr. Cindy, that we've had some, we've gone through some cases that, treating trigger points, and it does seem like it can be, really help release those trigger points. So we just don't.
Yeah.
Yeah.
We tend to use it a lot in the trigger points when it's us technicians, because we can't dry needle.
Absolutely.
So
Yep.
it's a really useful, if by chance it's a technician appointment, we can still do good without putting needles in.
Yeah. Yep. I would agree. Absolutely. And it's just, again, one of the many things that we have. So a level of evidence, which I thought was interesting on the human side, is that you can see, so one is actually your higher level of evidence for human studies. And so you can see pretty good, pretty good evidence that they're finding on for the low back pain and Achilles tendinopathy, patellar tendinopathy. That's another thing that we treat a lot on our side. So there's there's hope. One day we will actually get the studies. All right. Complications are pretty unusual. Again, I have found that as we've come down in our dosage from those higher, 0.3, 0.4 levels, that we just don't, certainly pain during treatment. And one of the great things about the piezo wave is that it is very focused. And so it focuses it past that skin point where you're going to get that, that stinging kind of feeling. And I just see a lot. I don't have, well, the only time that they are sedated is if they're coming off of imaging and we're doing that first treatment. As all, they're still sleepy, or they still are under anesthesia or sedation, and we'll go ahead and just treat them, because that's, we just grab that window of opportunity to treat them. But then the subsequent visits, we don't sedate them unless they are big bad working dogs that are not going to hold still for anything. Then we don't treat them or don't sedate them. Sometimes you can get some transient erythema at the site of the focus delivery. Again, just, a little bit of redness from, especially if you're way up there into the, 1,000 to 1,200, 1,500 pulses, you might get a little bit of redness, but that quickly dissipates, and have not had that be a significant problem for our patients. Not too many things that are contraindicated, but over airfield tissue. So be careful, if you're talking, like I might use it for a rib fracture in a bigger dog, but I would use that with care. I'd make sure that and again, very focused, I would be measuring it with ultrasound or imaging, and then know exactly what standoff I have to use, and exactly, and isolate exactly where I'm putting that thing. So a little bit unusual, but that's the big thing. And then of course, all of your neoplasias are, don't do it. Just don't do it. And then infections at the treatment site, of course. The clotting disorders would be problematic, because potentially you could, cause a real area of bruising or bleeding issues. All right. So again, the protocols. Where are our protocols? That's the tough question. Kind of how much and how often, and that's the challenge. But okay. Again, on some of the guidance from I'm trying to get Dr. Cindy out of the way here. Here we go.
I would never be in the way.
Here, I don't know why you keep popping back to the center there, but okay. All right. So just to give you an idea, and the intensities, these are unfortunately didn't give specific. I am I think that any studies that are published should have to give you dosage, which is essentially your millimeters per millijoule, millimeters. Gosh, I keep getting that backwards today. Millijoules per millimeter squared. And your total energy, based on the area that you are treating. I just think that should be in every study. So, but it's not, unfortunately. And so you get this just, low, medium, high kind of thing. But again, you do have to go higher for bone. I will say that's one caveat for bone, is that's when we do go up to the 0.2s to 0.3s, is if we're doing that higher level. Everything else on your tendinopathies, you're staying pretty low. And I'll get to all right. So again, as far as your just more kind of tricks for your treatment protocol, diagnose your lesions. We talked about that. Use a directed dosage based protocol that's recommended by your machine manufacturer. In this case, Piezo has got great charts that will give you at least a place to start and some guidance there. And then ideally you reevaluate your lesions. We have actually dropped that down to about a month post-treatment. But there are some readings where you see that they're doing them at 3 months, 3 to 4 months post-treatment. And so, but the bottom line is ideally you would look again at your musculoskeletal ultrasound and see what changes you have, potentially, that are occurring. Like with everything, we need objective data to say, is our treatments actually working? Are the things that we're doing for rehab actually working? And so part of that, we use a lot of gait analysis for that. And it's not always it's kind of like radiographs. It's not always a 1-to-1, but equivalents, like, they've got this much pain, their gait's going to be altered this much, but it does give you within, so it's not always applicable across animals, but within the animal, it's a good control for their own, this is what they started with, and this is how they're improving or changing as they go along. And I feel very strongly about this. It's my own opinion, but it should not be a shotgun treatment. Unless you are treating a treatment of a lesion, and that's why I put that as a if you're treating a specific lesions, like say within a tendon or within a tissue. A broader approach might be appropriate for pain management, for myofascial work, for lumbosacral, disease, or, lumbosacral issues, those sorts of things. But if you are actually treating that lesion, know what you're treating, know where you're putting that beam, and put it on the lesion. This group had done a fairly nice, this is a release not too long ago here about what does the ultrasound change, what do the ultrasound changes look like? They looked at supraspinatus and biceps tendinopathy, and over the time they did their treatment, and this was low intensity, and so this was piezo. That we had an improvement of the tendons sequentially on that reexamination after treatment with the ultrasound. All right, so a couple of cases. Again, our shoulder tendinopathies, we tend to see tons of them. We see a lot of hunting dogs. This is our little Cole here, was just in this week, and is so typical of what we see. Is wonderful German short hair. Had a supraspinatus tendinopathy that was quite profound. He belongs to a vet. It does a little recreational hunting, and just an super active dog. He's young. He's only about 3.5 or 4. And had some pretty marked changes in his supraspinatus tendon. He's also got a little bit of elbow dysplasia, and so he's got a couple of strikes against him. And so it's always the question, and I would encourage you, if you're seeing shoulder tendinopathies, to be sure and look for other things. So it's like if you're seeing hygromas in big dogs, in growing, in younger, larger giant breeds, look at their hips, see if they've got hip dysplasia, because they tend to bang down on their elbows and then lower their hips because their hips hurt. And so it just, have they been overloading their shoulder tendons because their elbows hurt, or because they've got, hip dysplasia, and so they are shifting from their back to their front. So, be sure and do kind of keep an eye out for other issues going on. But we do see it frequently in our hunting and field dogs that are in high impact sports, all breeds of dogs that have shoulder instability. So we've got some corgis that, with their notorious shoulder instabilities, that we've got some tendinopathies with those guys. And so it's a pretty common thing. Now we see a lot as referrals. And so, infraspinatus, very unusual to have infraspinatus tendinopathy, because again, just biomechanically, the stress that you're putting on those shoulders with impact and with eccentric loading, as those shoulders are flexing and that impact is happening, you're stretching those tendons. And so they're just more susceptible, because that's where most tendon and myofascial injury happens, is with eccentric loading. So in little Cole here, this is his left side down at the bottom, his right side up at the top. You can see you can see this calcification of the tendon here, and he's got a little enthesiopathy back here. And so he has some shoulder joint OA. You can see that just kind of as a comparison, kind of areas to look are along this pathway here for both bicipital and supraspinatus calcification, and then a cleaner joint here. His ultrasound, I really tried to figure out a way to show ultrasound images. It just does not work well on Zoom, and I couldn't really give you a good, so you're just gonna have to trust me on the, the found insertional and mid tendon body pathology. And that's what we do when we look, is we actually identify, do we have musculo-tendinous junction? Do we have mid-body tendon? Do we have insertionopathies, or any combination thereof? And then actually measure, how far we have to go with our pad, kind of each site. And so we treat, kind of those specific areas. This one was actually treated at a different place, and so their protocol is a little bit different. They did use the linear probe with the number 10 standoff. Whoops, you can see that they, were at this about 0.1, and then had 3 treatments. And then when we reevaluated, there was some improvement in the tendon, and certainly the dog clinically improved dramatically. So this, here we would probably would have done a little bit different treatment, but again, that's just, it kind of what works for you in your setting, is going to be the most important thing. And I forgot to put, sorry, I missed it was 1,000 pulses, because they used the linear, and so just kind of set that down. They did 1,000 pulses, and I thought I'd put that in there, so. Okay, for us, you can see another one here, a nice calcified tendon.
Mhm.
And we, in this particular one, we also saw insertional and mid-tendon body pathology, because that's where we usually see it. Sometimes you'll see it up into the musculotendinous junction or up into the muscle itself, and we will add those treatments if we need to, but this is definitely your most common two areas where you're going to see. So we do a little bit lower on our Hertz, just would think they tolerate it better, but with the number 15 standoff based on our measurements, level 6. And so I almost uniformly go up to at least 0.1 millijoules per millimeter squared. And then we divide our pulses into our separate sites. So we did 750 at each site. So really kind of a total of 1,500, but it was kind of at 1 centimeters, each movement. And then once weekly for 4 treatments, and then again saw improvement in reorganization on the repeat ultrasound. One of the things to note is that you are not going to resolve your calcification in those chronic tendinopathies. Shockwave is not going to resolve that. So that's important to keep. I mean, that's why you have to use that kind of energy level for lithotripsy to actually implode your calcification or your stone. You would damage the tendon. You would blow out the tendon before you could quote dissolve the calcification. So just keep that in mind. It can improve, and especially if you have early minor ones, you can see that reorganization. But when you've got a big calcified tendon like this, you're not gonna resolve that. So just keep that in mind. Now, clinically doing much better, but you're not gonna resolve that. So this just for as far as the anatomy of it, kind of where we're treating, where we're putting that, that focal point again with our, because we're using our round probe, and not the linear probe. And so we're just, and we literally, it goes on there and we literally rock it just back and forth, just but that head, that point, that focus point stays on the point of interest. All right. So that's an example of how we would look at how we would go through the imaging process, and we do a lot of MRIs too also on them, because a lot of them we get where they've been not really responsive greatly to treatment, and we're looking for kind of other things like do they have a labral tear? Do they have uh, glenohumeral ligament damage? Do they have something within the joint itself to go along with their tendinopathy? So that's where we do a lot of MRI imaging. So as far as our gastrocs, we see a lot of those. This is kind of our classic. So you can have your complete rupture where you're going to have them completely plantigrade. We don't normally see that. These do tend to be a degenerative type. They're almost like they just match the other angulation of our cranial cruciate ligament. Achilles are obviously always under pressure as quadrupeds, and so we see this as a degenerative process, and so it starts long before we see them clinically. By the time we see them, a lot of times, unless they have had an acute rupture or injury, we just, it's that slow decline, and so we see them when they're thick and they're ugly and they're chronic at that point. But that little club foot there is the partial, it is the gastroc, so in other words, the superficial digital flexor is still intact, and that's what pulls those toes up. This is normal, our normal anatomy up here. So we've got the superficial digital flexor tendon that comes around and down to the bottom of the foot here. And then the gastroc tendon, so either of those or both of them can rupture. Both are clear, it's plantigrade. They walk on their hock. The point of their hock is all the way down on the ground here, but this is what we normally see. And again, with that club foot pulled up. So we do have, and this is this particular lab here. He's a hunting lab that, just lives for hunting season. He's about 8 years old now, so he's a little bit older. Can see those changes, those calcifications. We had a whole bunch of punctate changes there, thick tendon, thick insertion. We see the same thing. I did manage to catch a decent still on the, if we look kind of more up here, we can see those fibers are a little bit more normal. And then we get, so looking okay. And then we get into just this bulge and we see this drop out of fibers that have been torn and leave the black hole. So this is particularly where we might put PRP in conjunction with Shockwave. And that's sort of a whole nother story in itself. So, but we do PRP only if we have deficits in the tendon. You do not want to inject into a tendon that has architecture that we see that fiber, because you will disrupt those fibers. So I always do Shockwave with those guys. The same group that did the tendon study, or the shoulder tendon study, Julia Thomason and her group, showed that Shockwave was as effective as Shockwave plus PRP, and both of those were more effective than PRP alone. So to me, it's like, why be invasive? Treat with Shockwave first, and then, but if you've got large deficits, then you can also consider PRP. All right. And so again, we had a 3-point. I didn't have all of the pictures, but we did, the appropriate standoff pad. And this just gives you sort of the overall, so 5 to 6 hertz, the appropriate standoff pad again. And this is where you could actually measure, just pull out your ruler and measure kind of here to here, where you would think that lesion would be mid body of the tendon. And that'll give you your standoff pad. And then level 5 to 7 around 0.1, millijoule per millimeter squared, and then 5 to 750 pulses, per site. And the 3 to 4 treatments once every week. Perform redo your diagnostic ultrasound, and that's what we just did: insertion, mid body, and then moved up a little bit higher at the because it's a nice long tendon, and we were able, so we had it mapped by centimeters, how many spots we needed to treat. Okay, the other important thing is, quite frankly, you have to unload those tendons. This is in hindsight on this dog. There's reasons when we worked with our group out in Washington, our orthotic group, that we chose a non-foot, or, an open foot not yet. Brace, but I would put him in a footed orthotic if I had to go back and do it again. So just to give him a little bit more support, because we could never get him. He still remained he had a very minimal movement hinge on it, but I would have liked for him to not have quite as much movement still on it. But they need to be in orthotic, some sort of coaptation, and then appropriate, again, loading and retraining of that tendon as you go through treatment. We use our whole body vibration a lot for that, to create micro oscillations in the tendons, in conjunction without doing any range of motion. So we do isometric work, and those oscillations. So that's kind of how we put together our Achilles tendons. And we do the same thing with shoulders. We do this very, very same, a lot of isometric work, a lot of micro oscillations, which you can do with bands, with your band treatment. You're doing those micro oscillations, and we just happen to use whole body vibration for that. And so this is typical, just all of these horrible Achilles tendinopathies that we get, these little club toes here. So again, SDF is intact, gastroc is torn, and just, these are bad, and they need to know that these are going to be real challenges to get them to treat. So, all right. Because that was kind of the fast and furious tour. Any questions? Let me pull up kind of everybody here. Thoughts, or absolutely feel free to to capture our email. And actually, I should put our vet SMR. So it is the vet is in VET SMR for sports medicine rehab, all one word, at missouri.edu. that comes to our service in general, but you're absolutely welcome to at any point, email me if you have questions.
Any questions, guys? So that middle one, that picture there. Where are you treating the whole, like?
Yeah,
I mean, that's
a,
hard to go point to point. So I guess,
absolutely. Agreed. I probably actually would do the linear probe, with your
okay.
line oriented this way, and would treat kind of lateral, medial, and
And-
end on, right at the point there, because that just, oh, that thing is so ugly. It really is. What do you think? What would you pick?
No, that would make sense if he's large enough for the linear to make contact.
Mhm.
Sometimes when something's like, and as I preface always, there's 1,001 ways to treat,
Mhm.
as long as you get the tissue in the focal zone for the right enough treatment. But sometimes I'll move through it just very, very slowly. And I say move through it millimeter by millimeter.
Yeah.
And then if he does kind of uh, respond at one place, focus on that place. So,
Yeah, absolutely. No, and that's a good point to, I would, because I used to use it more. I used to use the application, the trode, more like almost like a laser, where probably, but I do think that there are still times, like I agree, if I didn't have the linear probe, I would go just kind of, and I probably would do 500 pulses, at each side, or 500 to 750 at each side, and just very slowly, pop, 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 pop as you're going down, and just creep down, the line, for that number of pulses, and then come to the backside, and then come, lateral. Yep.
And one question that I have, because I was working with somebody, and it was probably a little more equine, but what do you feel about working through the muscle above either like in the muscle body of the biceps, or the muscle body um, above the Achilles, to relax it enough so there's not quite as much pull?
Yeah, so that's where biomechanically you really can't create that. So I would say for your Achilles, you do need some sort of coaptation initially, ideally. And that can be, you can learn to do like thermoplastic splints that are super fast, and can give you that support that you need in that initial time period. But it's been so hard to get to that point for me, because I'm like, we need to treat this. It's going to be okay. But the truth is biomechanically, you cannot unload that without some sort of coaptation.
Okay.
You just can't. I mean, you can give some temporary relief. You can do all of that. You can make it more comfortable, but you are not going to shut down that biomechanical pull. You just can't. You can't, unless they have that leg up. You can't do it. And so that's where you really have to have some sort of, and truthfully, in one that's like this, they need
Oh
to
yeah.
they need to be an orthotic for, and like our other dog, he hunts in his orthotic. He loves it. He hunts in it. So he does great, and but we explained this is going to be, we can help improve this a bit, but it's not going to magically, resolve that horrible chronic tendon. So, but this one did look better. This was kind of the initial presentation where this was an acute, more of an acute, so this was actually the second one that she had done. And then it got, because you can see both of them are kind of ugly, but it resolved down more to just a
More
sort of
normal.
gnarly looking, you can see a little bit of that suggestion here of kind of more knotted, versus this just, bulbous, more
Inflammation.
acute on chronic. Yeah. Yeah.
Cool.
So,
Awesome.
but they're fun. I mean, this is go-to, no question about it, for tendinopathies and musculoskeletal type stuff. It's pull out your Shockwave.
Super fun. And good results. Does good for the pet.
Yes.
Anybody else have thoughts, questions, comments tonight?
It's been
All
a very
right.
quiet group.
It's a quiet group, but some are quiet and some aren't. So you guys, if you do have questions, think of questions, want to, work through different protocols, feel free to reach out. As I always say, there's 100 ways to do it.
Yeah.
Um, you know, I, you know, I didn't know about the air bubbles as much as you brought it up. I agree. The one thing I think we do often, and it brings up why the dosing can be complicated from
Mhm.
treatment to treatment, because I think sometimes we do get that little bit of air. Our owners won't let us shave, or we put the gel on a different way, and we increase our dose to compensate for it.
Yes. Yep.
So one of the reasons it's so hard to create exact conditions for clinical situations,
Yep.
it's not a simple answer. And I think we all have to keep in mind that, it's not simple.
Yep.
But if it works, the ultimate goal is a positive clinical result. So
Right. And that's where I really, if it's at all possible, is do those follow-on musculoskeletal ultrasounds, to look, or gait analysis, or, something that can give you some objective data to say, hey, this is, but the studies are showing that, that we are seeing positive ultrasound, measured response. So that's good.
yep,
Gives us
yep.
yeah. All right.
Oh, well,
Well, it
thank
was
you so
fun as
much for
usual
your
to,
time.
yeah, you bet, to chat, even though everybody was very quiet.
We have some new faces, but thank you everybody, and you know where to find us if you have questions, and I appreciate your time and effort.
Of
Thanks,
course,
Dr. Pierce.
always, you bet.
Take
Okay.
care.
All right,
Bye.
bye.